Hey guys, Woodruff here. So this video is going to actually be a review video. I did this cardiovascular review in my class. It just has some different variety of open-ended and other types of questions that you may see on the exam, but also it's good practice to cumulatively break things together and to start to, try to remember some of the stuff we learned in the beginning of the cardiac section. But it's a good way to practice test taking strategy, content, and kind of start bringing things together. So this is going to be a more basic one. I definitely went more in depth in person in my class, and it's hard to kind of do this. I do this as like a quizzing thing with my students. So it's a lot easier to do this kind of stuff when there's an engaged crowd. So forgive me if it seems a little bit more short to the point, but you could definitely take this and do this with friends. You could take it, just pause me as we're going throughout and try to answer it before I answer it. And see how in-depth you can go and what other questions that you could ask yourself, etc. So, but hopefully it's helpful, if nothing else, just to look at the questions yourself and see what you can answer. So let's get started. So we're going to start with an open-ended question. So we're going to start with content at the beginning of the cardiac section, which is where we start with blood disorders. So the first question is, what are 3 classic signs or symptoms of anemia? So anytime a question asks for classic signs or symptoms, you want to think about things that, like, if you looked at them, like these are like the hallmarks, or you can look at these symptoms and be like, boom, 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 that's anemia. Versus, like, there are, like, it's hard with anemia because there are some more general symptoms. They are more general, but you want to think about if is whatever ones are most specific or most tailored to anemia, that can be connected with this disease process. So when you're looking at this, ones that come to my mind, there may be more than this, but the big ones that I think about, because the other thing I'll tell you is, when you're studying symptoms, you really want to look big picture, versus overall, what does this patient look like, versus trying to memorize 15 symptoms. But overall, I would say, pale, weak, tired. You could also, tired and fatigued are the same thing. You also could say like short of breath, things like that. But those are going to be more classic symptoms, or they're going to be those ones that, if I'm thinking of anemia, I want to literally visualize a patient. I see this patient that's really pale, and they're pale because they don't have the red blood cells. They're weak and tired because their body doesn't have the energy stores and the oxygen to the tissues where it needs it. They are short of breath because they're not getting enough oxygenation, things like that. And as it gets more severe, they can have other symptoms, but if I'm thinking just classic anemia, this is what I'm thinking about. All right, so now we're going to do a multiple choice. So a nurse is caring for a client with aplastic anemia. Which intervention is most helpful to prevent complications of thrombocytopenia? So we go back and remember aplastic anemia. A is without. And so it's not that they're without plastic, but they're without all the cells. So they're low on red blood cells, they're low on white blood cells, and they're also low on platelets. So we actually could ask 3 different types of questions. We could ask you a question like, what intervention can you do to help with having low white blood cells? We could say, what could you do if you had low red blood cells, and then also low platelets? So you want to look at these questions, or a question we could ask, it's usually going to be tailored to one of the 3 problems in aplastic anemia, and you have to figure out which one it is. And then you also have to think about, for this one, what's most appropriate. So all of these things might be good for aplastic anemia, but specifically aplastic anemia, what helps with thrombocytopenia? So if I look at this correctly, let's say I don't remember what thrombocytopenia is. Thrombo, or thrombus, is like a clot, and penia, I think puny or small. And so when people are low on the cells that help us to clot, that's our platelets. Our red blood cells help us to oxygenate. Our white blood cells help with infections, or fighting infection, that is. But our thrombocytes, or thrombocytopenia, is talking about there's a low number of platelets. So this is saying a person has aplastic anemia. which of these interventions is going to help to stop them from having such bad complications of not having enough platelets. So with a question like this, I could sit there and start to think about, okay, low platelets, what am I concerned about? I'm going to be worried about bleeding, stuff like that. So I get that idea in my head. Let's go through though. A says encourage them to get plenty of rest and stay hydrated. And so for this one, that's a good general for most people. Maybe getting good rest, drinking fluids that might be able to help a little bit in general with like general anemia. But that's not very specific. I don't see how getting rest and staying hydrated is going to stop you from bleeding, because that's the big thing we're looking at here is specifically what can we do to stop you from having a complication related to bleeding or having low platelets or not being able to clot as easily. So teach them to avoid crowds and wash their hands frequently. Well, I know for sure I want to do this for aplastic anemia, but is it going to specifically help with my platelets or my low platelets or not having enough platelets? So I think that this answer would be true if the question said which intervention is most helpful to prevent complications of neutropenia or low white blood cells. Encourage them to remove clutter from the floor at their house. Well, this one may be because if they have clutter on their floor, it could lead them to trip and fall. And if they can't stop, if they can't clot or if they can't stop bleeding, they could bleed to death as a complication. So this is the one I like the best so far, but let's look at the last one. Teach them they will need to increase their intake of iron. So iron deficient anemia, definitely want to keep that in mind. That a lot of times the answers that are distractors for questions a lot of times on our exams are often questions that are correct for something else. So I have to think, okay, like when they have the anemia portion in the aplastic anemia, like the low red blood cells, does it have anything to do with iron? And no, those are two separate things. So I mean, someone with aplastic anemia, they also may need to increase their iron. I mean, possibly, but that's more with iron deficient anemia. But even if so, let's say that they do need to increase their iron, is it going to stop them from bleeding to death? No, that has to do with their red blood cells. So only answer here that has to do with your platelets, or the only thing here that could help you to not be so at risk to bleed to death is going to be C, because if I remove clutter, I have less stuff on the floor, less chance of tripping, falling, and having an injury. All right, so it says put the following actions in order from first to last. So we're doing blood administration. So we have to think about what we want to do first. The first step here is going to be, let's look. So the first thing I want to do is check that they have signed consent. So I want to first make sure that we even want to do this in the first place. So check one, I should say. First checkbox is that, do they have signed consent? So that'd be number 3 first. Then I want to make sure that I have all the tools and supplies and everything that I need. So appropriate IV access would probably be the best next action. Then so that's 3, 2, and then I would probably get a baseline set of vital signs. That's going to be number 4. Then I need to do a 2-nurse sign off with the blood. So that's going to be number 5. So we're at 3, 2, 4, 5. Then I'm going to administer the blood, which is 1. And then last but not least, I'm going to check for signs and symptoms of a transfusion reaction. So that would put it at signed consent, number 3, verify IV access, number 2, baseline vital signs, number 4, 2-nurse sign off, number 5, administer the blood, number 1, and then look for a transfusion reaction, number 6. Now, this is a great place to study more, some great questions to ask yourself here is that how will I know a patient is having a transfusion reaction? What are some common transfusion reactions? What other supplies aside from having IV access do I need? This is a great time to practice, how long from the time they pick up the blood from the blood bank, how long until we can, how long do we have until we absolutely have to start administering that? And then how long once we start the blood do we have that until it needs to be done? So those are some really good questions to ask yourself and start really thinking about those other scenarios that add on to this. And then also, like, how would we intervene? Okay, so let's say the number 6, is that we check for signs and symptoms of a transfusion reaction. Well, what if it comes back that they are having a sign or a symptom? What am I going to do? So yeah, so remember, the answer for that is always first, stop the transfusion. All right, so let's get this giving blood multiple choice. A nurse is caring for a client who has an order to transfuse 2 units of blood. Their most recent hemoglobin is 6.5. They have a history of heart failure, CAD, and hypertension. What action is most appropriate for the nurse to take for this client? So there's a lot of information in a question like this. So, here first I have to look, and it says that they have an order to transfuse 2 units of blood. I know here that there's some sort of plan or preparation to give 2 units of blood. Their hemoglobin 6.5. Then I need to consider their histories. They have a history of heart failure, CAD, and hypertension. So they have a lot of cardiac history. I do know with heart failure, they don't handle a lot of fluid, so I need to take that into account. It says which action is most appropriate for the nurse to take for this client. So the first is call the physician because the order's not appropriate. So for that, it would have to be like, if I did this, it would cause harm. If I'm looking at this, their hemoglobin 6.5. To get 2 units for a hemoglobin of 6.5 sounds pretty appropriate. And so I don't see anything that's contraindicated here or not appropriate. The next one is give 1 unit of blood in your shift and 1 on the next shift. Usually it's not like, it's not that they have to be given directly back to back, but usually we don't want to wait if their hemoglobin 6.5. We definitely, if they have a cardiac history, it can lead to some ischemia, other issues, or if there's not enough oxygenation to my other organs, especially already having heart failure, could lead to a lot of complication. So it's unnecessary to give 1 unit now and say, okay, well, the next shift needs to give the next unit, like to spread it out like that. Administer the 2 units quickly due to their low hemoglobin. So for most patients, this would make sense. I would want to get it done quickly so that I can go ahead and get them starting to feel better. But because of their history of heart failure, I don't think it's appropriate to give it that fast. Then last but not least, it says give each unit of blood slowly over a period of 4 hours. So out of all these choices, this sounds like the most appropriate. I'm going to give each unit of blood slowly over a period of 4 hours. So it's going to take me a little time to do it. But if I do it slowly, it's going to decrease their risk for having a complication. You have to think about what is that complication that they could go into. They have heart failure and they're receiving a lot of blood back to back. That complication is also known as, it's a transfusion reaction, I should say, that's known as fluid overload. And this would be a good time to be like, okay, if they went into that, what would it look like? Well, their lungs would sound really wet. They would be maybe complaining of shortness of breath, decreased oxygen saturation, and then think about, okay, well, what am I going to do? So these are the patients that we, maybe slow the transfusion, sit their head of bed elevated, might get a chest x-ray. They might require diuretics. That's the other thing, maybe additionally, this patient might need some diuretics after or in between because they need the blood replacement, but they don't need the volume replacement. So anyway, as a whole, the best answer here, the only one that's really appropriate and that will help meet the patient's need while also keeping them safe and preventing a reaction or decreasing the risk of a reaction, is going to be D. All right, so now we're getting into iron deficiency. So iron deficiency, remember there's the 3 types of blood disorders, anemia, et cetera, that you need to know about. You need to know about iron deficient anemia, you need to know about aplastic anemia, polycythemia vera, and then blood transfusion. So getting into iron deficiency, this is a SATA. I know you guys love SATAs. So it says, which of the following are appropriate to teach a client receiving iron supplementation? So this is a teaching question, and it's looking at what is appropriate. So we're looking for what is right. Should I teach a client that the iron that they're receiving may change the color of their urine and oral secretions? So I know that iron changes the color of something, but I don't feel like it's the urine and the oral secretions. I know there's stuff with like drinking through a straw and with the oral preparations, but I don't feel like it actually changes the color of your secretions. So I'm going to hold off on that one for now. You will need to brush your teeth before and after administration of this medication. So I don't believe that's true. You definitely have to be careful with the teeth. I think you want to drink it through a straw and to avoid staining your teeth, but you don't necessarily need to brush your teeth before and after. Again, might also depend. No, I don't want to say that. I don't even want to say that. So, but it's not really indicated. But a good thing you can do here is there someone else that needs to brush their teeth a lot? Because the thing is that a lot of times, again, we use answer choices on some of these that are correct for other things you need to know, and sometimes students just get the information mixed up together. So remember, for calcium channel blockers, that they can have gingival hyperplasia. So they don't necessarily need to brush their teeth before and after, but they just need to brush their teeth really well. So just like a little hypertension study at the same time here. So far, I don't like A and I don't like B. I don't think these are things that are appropriate for iron. The next one, you may need to increase your intake of fluid and fiber while on this medication. So I like this one because I feel like constipation is a side effect of iron supplementation, and fluid and fiber could help with that constipation. Let your doctor know if you have a change in color to your stools. So I know that they have a change in color to their stools, but is it concerning? Like, is the doctor going to do anything about it? I think the answer there is no. I think this is one of those things where, if they have a change in color of their stool, it's expected. Their doctor's just going to be like, yeah, and like there's nothing for them to do or to change, and it's that black tarry color that it changes to. The last one is take this first thing in the day on an empty stomach. So I know it wants to be on an empty stomach, and taking it first thing in the day sounds good, so that they because they're going to usually have an empty stomach, etc. So that sounds good to me. So far, or not so far, to finish, the ones that I think are true and or correct that we are going to include are C and E. All right, concerning assessment findings. Which nursing assessment is priority to look for complications in a client with polycythemia vera? So polycythemia vera, this is the one. So poly is multiple. And so compared to aplastic anemia, A is without, poly is multiple. So this is where they have too many, or like not an overgrowth, but a proliferation or too many cells. So polycythemia is too many red blood cells, white blood cells, platelets, and they're really high risk for clotting. Clotting is the big thing. So is it going to help me assess for clotting or other complications to assess for their last bowel movement? I mean, I probably want to know what that is, but it's not going to be top of my list. Ask about instead of ask for. Ask about one-sided limb swelling, redness, and tenderness. This could give me some information if they had a DVT. We're going to look for that one-sided swelling, redness, and tenderness, which could be a sign of a blood clot. So this is the one I like the best so far. Assess color and consistency of sputum. Well, this really doesn't, they're not at risk for infection like aplastic anemia. I don't think that that's going to give us any information that's going to tell us how they're doing, especially not related to clotting. Inquire about any odor or painful urination. So again, another infection thing. I don't think the polycythemia vera, they're more risk for UTIs. So I don't think that any of these are related. I think the only one that could be a sign of a complication would be the sign of the blood clot, which is the one-sided limb swelling, redness, and tenderness. All right, so what are 5 risk factors for deep vein thrombosis? So I got some of my students earlier with this because they couldn't remember Virchow's triad. So if you remember Virchow's triad, that's like the 3 different general factors that can lead someone to getting a blood clot. And so the Virchow's triad is that any sort of blood stasis, or blood is not moving, being hypercoagulable, or having medications or other things that are going to put you at risk for having a higher chance of your blood clotting, and then endothelial injury, or injury to the inside of the blood vessels. So we're looking for different stuff. So what upsets the inside of my blood vessels? Things like diabetes. We caught certain drug, and of course it's not plaque problems, but what I should say is, because we're talking about in the veins, but what am I saying? So diabetes, also any sort of like IV that's inserted, like if they have a catheter or a line, like a central line, this is going to increase their risk. So endothelial injury, think like IV catheters, like peripheral or central lines, could increase your risk, especially bigger catheters like PICC lines and central lines are going to put them more at risk. Then you think about immobility or stasis of blood, immobility, heart failure, AFib, long trips where you're not moving a lot, that's going to increase your risk. And these are just a few to throw out there. And then the last one is the hypercoagulable state are people that are more likely to clot in general, and that's going to be people on like hormonal birth control, cigarette smokers, and things like that that increase your risk of clotting. All right. So, arterial versus venous. So it says for each of the following statements, indicate whether it is associated with arterial, which is A, or V for venous. And I'm not throwing gang symbols. These are what we do to help to remember what to do about arterial versus venous. So it'll make more sense in a second. So the first one says dangle legs to relieve symptoms. So which one do we want to put the legs down to relieve symptoms? So to dangle the legs to relieve symptoms would be A for arterial. So this is how I remember the A for arterial. You put your legs down, you dangle. So also the word, if you see the word dependent, all these D's mean the same thing. Dangle, dependent, goes down. So that's going to be A for arterial. Has weak or no pulse. So if they have weak or no pulse, this is a blood flow to the foot problem, which means it's a problem getting blood flow down. So again, we got arterial. Intermittent claudication is common. So that's that intermittent, calf pain or leg pain, depending on, where they have their pain. So that's going to be related to, what do you call it? It's like an ischemic pain. So we have it when we have intermittent claudication is going to be with arterial, and that's like when pretty much effectively they're up, they're walking around, they already have narrow blood vessels and narrow arteries, I should say, getting blood flow to their feet, and so in their legs, if you already have this narrow blood flow and then it gets even more constricted because you're up exercising, moving around, that's where they can have that intermittent ischemic pain. Walking helps to improve symptoms. So this is a patient that if they get up and walk around, their pain is going to be better. So someone with intermittent claudication, their pain is actually going to get worse if they're up and walking. That doesn't mean we don't want them to walk. We'll talk about this. We do want PAD people to walk, but walking is not actually going to help make them feel better. But for someone who has venous problems, elevation, walking or movement, and compression are going to be my best friends. So walking helps in venous because it helps to create a squeeze or an increased flow of getting the blood. Because remember, venous, the problem is getting blood from my legs and my feet back to my heart. So there's no pulse problem, no flow, like no blood flow, like we're tissue and oh, sorry, my cat scared me to death. Tissue or cell death is happening. But what's the issue is there's just a pooling of blood, or blood is like not moving forward. So walking will help to improve venous because it's going to help create that muscle pump in the legs to get blood back to the heart. Decrease that pooling. And so additionally with venous problems, if we're walking, it's going to improve that blood flow. It can remove some of that heavy, dull, achy feeling that they might have in their legs. Skin is pale. So we have to think pale means lack of perfusion. So if I have lack of perfusion, what color is it going to be? It's going to be more of like a pale white. Whereas if I am getting good perfusion, it's going to be a like red brown kind of color because it's full of blood. So I have to remember arterial, they have a perfusion issue. Like I'm having trouble getting any blood flow to my feet, tissue can die. Whereas venous, I have a pooling problem. What do you call it? So which one is going to be pale? So if I'm having a pooling problem, that's not going to be a problem where I have a blood flow issue. But if I have an arterial problem, it will be. So arterial is the one that the skin is pale. Then ankle calves are browned. It's going to be the opposite, where again, like I was just bringing up, if I'm getting good blood flow and stuff like that, but there's pooling of blood, what can happen is there can be kind of a browned or what do you call it, even red color to the ankles and calves, just as an accumulation pooling of that, all of those blood cells and the fluid in the legs. And then also like that's where skin breakdown and ulcers happen. So far we so for this slide we have dangle legs is arterial, weak or no pulse, arterial, intermittent claudication, arterial, walking helps to improve, venous, skin is warm to touch. Did we do that one? I don't think we even did that one. I'm sorry if I skipped that one. Skin is warm to touch is going to be who has good blood flow or who has good perfusion. If I have good blood flow or good perfusion, it's going to be warm. And so remember arterial, they're going to be cold and pale. So which one's going to be warm? It's going to be venous. So warm pooling of blood, is going to be venous. So we have skin is warm to touch is venous, skin is pale is going to be arterial, and last but not least, ankles or calves are browned. That's going to be a venous problem. There's a lot more that could be included here. I have some of my other PowerPoint for arterial versus venous, but you should definitely go through and maybe make like yourself like a little table or start to see if you can brain dump and see if you can differentiate these two. They're like more stuff like where do their ulcers happen? What do their ulcers look like? What treatment do we do for ulcers, arterial versus venous? The list goes on. All right, so now we're getting into some more vascular disorders, and we're going to do a true or false. So it says, for each of the following statements, indicate whether it is true or false. So the first one says, quitting smoking is the most important lifestyle factor to modify for PAD. So I know that quitting smoking is super important for all cardiovascular, but it's saying the most important lifestyle factor. And this might sound odd, but this actually is very true. Quitting smoking, like you might say like, oh, they need better diet, decrease cholesterol, lose weight, all that stuff, decrease their blood pressure, and all those things help. But they actually, research has shown that the most modifiable and the most helpful factor to change for PAD is going to be quitting smoking. Quitting smoking can, it's not going to change the fact that they're at risk for PAD, but it's definitely going to decrease it's going to help to improve their outcomes. And then I talked about in class about how compared to other disease processes and stuff like that. Quitting smoking, most of the time, like quitting smoking is going to quitting smoking is like, it's never going to be in like an option where it's like, oh, hey, like just smoke less. Like that's never going to be a good option. Like quitting smoking it's always going to be all or none, where alcohol, it's going to be like you can do alcohol in moderation. So if you remember with cardiovascular, 1 drink is okay for men. So 2 drinks are okay for men, 1 drink's okay for women. So just kind of keeping that in mind. I feel like there was something else I was going to say here too. Then I think the thing I actually brought up in class too is just about the fact that most of the time, quit smoking, it helps, but it doesn't change the fact that you've done it. But they actually say that if it's, I think it's with, when I say it's like with maybe CAD, that if they quit smoking and don't smoke for 10, 15 years, they can significantly decrease the risk, like almost to where they're not like at risk the way that they were used to be when it comes to CAD. But yeah, so I'm just trying to hit home the point that quitting smoking is super important. So then encourage walking in a client with PAD. When it comes to walking in a client with PAD, this kind of goes back to what we were talking about before when it comes to peripheral artery disease, that when a patient with PAD is up and walking, it's going to hurt to walk, especially long distances or depending on how their flow is, because they're going to get that intermittent claudication. So you might want to, go here and say, ooh, and so by the way, the first one is true. So this next one, you might go automatically to, oh, if it hurts when they get up and walk around, I'm going to tell them not to walk. Well, there's really no patients that I tell, hey, lie flat, don't move, just stay still. So encourage walking is going to be a very important thing for PAD. So think of it this way, is that a patient with PAD, they're not going to feel better or necessarily have immediately improved symptoms by walking, but it is going to help to help with weight loss, their mood, their energy. It's going to decrease other risk factors, help with circulation. So we do want to encourage walking, but they might have to do those break periods, like the energy conservation techniques, just because it can be a lot for them. So hopefully that makes sense. So walking is good with PAD. All right, so true. Clients with PAD will require anticoagulation. I know there's only a few people that require anticoagulation. I know it's like AFib, they require anticoagulation. Then there's also, patients with heart failure that have an EF less than 20%, or I think also people that have DVTs. Well, we have to sit there and, already have a blood clot. So clients with PAD have flow issues. And we talked about this in class that, there are going to be some patients with PAD that end up on, heparin drips and things like that, but that's real life. In nursing school world, we are talking about PAD for an average med-surg patient. And just like a run-of-the-mill patient, if patient comes in and they're like, "Oh, I have PAD," I'm not like, "Oh, get them on a heparin drip stat." Like, they do not need anticoagulation. They do need an anti, though. They're at risk for clotting, but they don't actually have a clot, or they're not so high risk that they require anticoagulation. So what they need is an antiplatelet. So this statement is false. Clients with PAD will require antiplatelets, not anticoagulants. And that antiplatelets, remember, helps anti-clogging, anti-plaques. And I don't want to say anti-plaques. It's it stops the platelets from sticking together. So if there is plaques, it stops them from having the platelets form a platelet party on top of plaques and make a bigger problem. So clients with PAD will require antiplatelets, not anticoagulants. So that statement is false. Regular use of Tylenol and ibuprofen can help with PAD pain. So I know that they have pain in their legs, the intermittent claudication, but it's not like a musculoskeletal kind of pain. So I don't think that ibuprofen and Tylenol can help. I think they need something that's actually going to help. So think of this like angina. Like, we don't give people Tylenol, ibuprofen to help with chest pain. So why would we give it for PAD pain? So what do we give? Excuse me. What do we give to patients that have the intermittent claudication? We have to think, okay, what do I give to a patient that has angina? Well, I give them vasodilators. So it's the same here. There's special vasodilators, the cilostazol and the pentoxifylline. Both of those can be used to help vasodilate, because that's the problem. Remember, they're having pain because their limbs are literally screaming out, I'm so hungry for oxygen. So Tylenol, ibuprofen can kind of try to block that, but it's not going to block the problem. That they're not getting oxygen the way that they need to, and their body's screaming for oxygen. It's not the same kind of pain as like musculoskeletal pain. So this one is false. Priority assessments for PAD include a peripheral neurovascular assessment. So this is an arterial problem, so it's a perfusion problem. So for PAD, you're going to need to check the pad of their foot. If you like that, you need to check the bottom of their foot. And you're going to do your 7 P's and 1 C. So let's see if I can get them all. Let's see: pain, paresthesias, poikilothermia, let's see, paralysis, pulse. We have the pressure, like edema. And let's see, pallor. So color, temperature, cap refill, pain, numbness and tingling are the paresthesias. We're going to look for paralysis or ability to move it. We're going to feel their pulses. We're going to look for edema, all those things. But the priority ones, if you want to look at your top ones for PAD, you want to check their pulses, and you want to look for paresthesias, or ask about paresthesias, I should say. All right. I'm going to take a quick water break. Hold on a sec. I'm back. And as I, sip from my son's water bottle because I'm lazy, I'm realizing that he may, possibly have strep right now, and immediately regretting this decision. So hopefully this does not impair me from being able to, do lecture for the next couple weeks. But we'll see. It's almost spring break. Yay. Anyway, so what are 5 suggestions for lights? I was like, let's see if I can. And forgive me, I lectured all day and had meetings all day. So as I sip on this bottle of bacteria, don't mind me, I'm not dying. Just a tickle in my throat for now. Anyway, 5 suggestions for lifestyle changes to a client with varicose veins. So this is a venous issue. So we remember some of the 3 big things that we do for venous: compression, elevation, and movement. So there's that, but then additional lifestyle changes. Varicose veins, people that are at risk are certain, professions or jobs. And so it'll be people maybe that, we could tell them to change their jobs, or not sit, stand, or change positions more at their job. So they're going to be less at risk. Obesity is a big factor to varicose veins. So we want to change that. Additionally, wearing tight clothing, especially around their belt area or their in their core area. Like if you wore really tight pants or things that constrict your circulation, it's going to make it harder for the venous return to your heart. So those are my 5 lifestyle changes. All righty. So, labs and diagnostics. So it says for each of the following labs and diagnostics, tell me what information it can tell you and how it will guide treatment for a client with cardiovascular disease. So this is just 5. Um, but in class we came up with a lot more, and you can definitely go on. I'm not sure why I'm losing my voice now. This is God's way of trying to tell me stop making this video. You've done enough for today. We'll go through these 5, but definitely recommend going deeper into some of the other ones. So there's troponin that, so that one is a lab, and it's used mostly like, and you always want to think about this as you're like looking at these, like which patients out of the disease process I learned about would we do this on? So we probably do troponin on someone with like CAD or CSA or heart failure to see how they're doing. We're looking for signs of heart cell death. So it can help guide treatment because it can help tell them that they are having a heart attack or having cell damage in their heart. That would be the main reason that I'm looking for it, or hopefully I'm looking for the absence of it. Then there's echocardiogram. So echocardiogram, this is a diagnostic test, and this is like an ultrasound of the heart. With this test, this is the one where I like them to lie left side lying. It helps to push the heart forward where they can see it better, and it allows them to do a couple things. I mean, they can look at a lot with an echo. They can look at the size of the heart, the pumping ability of the heart, the chambers, how they're doing, the valves, everything like that, the different parts of the heart. So an echo is going to help me guide treatment. So I would think it's going to be used for patients with like angina, maybe CAD, angina, definitely to see if there is ischemia in the heart, how is it affecting its pumping ability. Probably the one that it's most specific with is going to be heart failure, because we're going to look for that ejection fraction, which should be around something. I want to say your book says like 55 to 70%. So yes. So then chest x-ray. So chest x-ray, this could be used for a lot of different patients. I would say a lot of it might be the CAD, CSA, and heart failure again. I might see an enlarged heart, or I can also look for complications from different heart problems. And this is the place that I would want to, this is the test that I would want to look. This is a diagnostic test. Gives me a picture more to look at the structures, such as the structure or size of the heart, or the structures or issues within the lungs that can happen as a result of problems in the heart. Like, for example, with heart failure, you could end up with a pleural effusion. Or if I had heart failure, I could see fluid overload or fluid backup in the lungs. Cardiac cath. So this is more of a procedure, but I guess it is a diagnostic where you can go in and see how blocked the coronary arteries are. So this would be very helpful. CAD, CSA, they may do it in heart failure to rule out other problems, decrease stress on the heart, that kind of stuff. It's overall going to tell me how well someone is getting perfusion in their coronary arteries to their heart. And then what do you call it? We can also go in and do like actual interventions, like put stents in, get rid of plaques, that kind of stuff. Lipid panel, that is going to be for a lot of different patients. We might do it anywhere from hypertension, CAD, CSA. I'm going to do it for the vascular disorders. Well, that when I say vascular, I mean I should say arterial vascular disorders, anywhere that there can be plaque, heart failure, because we want to look for anything that's going to stress the heart out more. So we definitely want to be watching this closely to what do you call it? To look for plaque buildup, high cholesterol, because for some it's going to help. It's one of those modifiable risk factors. And then for others, like for heart failure, if they have high cholesterol, it's going to increase resistance in their blood vessels, and we want to do whatever we can to modify that. So, so it's a lot of times just looking at those modifiable factors. Ooh, look at this one. So this is asking for the normal for each of the following labs or diagnostic tests. And I'm sure there's more than this, and I know that you're probably thinking right now, oh, I'm going to put this on my note card. That's great. So the great thing to do here is it's asking for the normals, but then think about like, okay, what disease processes might I, need this lab or look for this lab, and then look at, some scenarios or think about some things that could come up, or what meds are these related to? Like what meds would I be, checking this lab for? So First one is HDL. So HDLs, that's my healthy or my happy, what do you call it, lipids. And so I want them high. So this is the one that I want greater than 45 for men, greater than 55 for women. And I'm going by the textbook standards that we have. These always can change, but, or you might, if you don't go to our school, you might have different one on your textbook. Troponin. So this one is a little bit different in the sense that, there is like troponin I, troponin T, but here's what I want you to focus on. It really shouldn't be elevated at all. And when we give you one on the exam, it's going to be significantly elevated or at least somewhat more elevated. It's not going to be where you're like, ooh, is this elevated or not? It's going to be very obvious if it is. And so troponin, like I know one of them is like less than 0.3 maybe, or 0.01. And there's another one that's like 0.1 that you want it less than 0.1. You can see it's a very small number because troponin should not be elevated because that is cardiac cell death. Blood pressure. So we want it less than 120/80. So it used to be we want it at 120/80. Now we want it less than 120/80. And this is a good time to pause and like you could ask yourself, hey, what are all the things I want to do when taking a patient's blood pressure? Like, what are all those rules? Like, this is a great open-ended question here, is like list 5 to 7 things that you want to do when taking a patient's blood pressure. Total cholesterol, what do you call it? So that's going to be less than 200. Potassium, 3.5 to 5. LDLs, these are our loser cholesterol. We want them low. And so this is the one that we want less than 130. Magnesium, this is going to be, I want to say it's 1.3 to 2.1. I could be making that up, but I'm 98.76927% sure that that's correct. But always double check my work. Triglycerides, those are the ones that we want less than 150. I know it can vary between men and women, but a good general is like less than 150. BN as a Nancy P. This is one of those diagnostics for heart failure, and we like it to be less than 100. Greater than 100 is diagnostic of heart failure or fluid overload issues or fluid stretch in the heart. Creatinine, it varies again, men to women, but usually you say about 0.6 to 1.2 is a good thing to go by. D-dimer, that's a sign of blood clot material, or that someone probably has a blood clot within them, that we want that less than 250. And then ejection fraction, we already talked about the 55 to 70%. So there's a lot more you can do with these. You can put them in scenarios. You can think about what meds are related to them. You can talk more about the disease process and practice that. But yeah, it's definitely good. All these slides, there's a lot of more room to grow and ask yourself more questions. It would take hours for me to go through and do all of it with you. So I'm sorry, I don't have the ability to do that. But teachers should always be like a jumping pad to jump you into, doing some of your own learning and asking yourself these questions, because, I can definitely, like, this is my comfort zone and what I know how to teach, because I've taught this content for years, but I'm not in OB pediatrics, other classes. And so, I really want to teach you strategies of how to take something and make it more, how to process it, look at it in different ways. And so hopefully this kind of activities will help you to visualize or do that for yourself. All right, so let's see, diabetes and cardiovascular disease. So diabetes interacts with cardiovascular disease a lot. In other words, hint, hint, know your diabetes for this exam. For a client with diabetes, what would we hope for their blood glucose to be? So I'd hope for it to be, definitely stable. Definitely in class we talked about, of course, we'd love for it to be like 70 to 100, but that's not even really realistic for a diabetic. So usually we start treating blood glucose around like 130 to 150s. So we definitely would hopefully like to have it, like lower than that. It just depends, because sometimes when patients are in the hospital, they're obviously fighting stuff, but obviously we don't want their blood glucose to be high, because it can definitely affect and cause damage to their vascular system. What medications can interact with diabetes and diabetes treatment? So you just want to remember, we talked a little bit about steroids can increase your blood glucose. We don't talk about steroids too much in CV disease, but always kind of keep that in your head. And then you want to think about when it comes to beta blockers, that all of them, they can potentially decrease your blood glucose, but also that they, beta blockers block beta. So they block your sympathetic nervous system, which can put you at risk for having hypoglycemia and not knowing it. It blocks that fight or flight. So what interventions can we do as the nurse to manage diabetes and cardiovascular disease? So you want to think about that when we do their diet, we usually do a heart healthy and diabetic diet. We also manage the diabetes, of course, lifestyle changes, diet, exercise, weight loss, that kind of stuff. We want to make sure to recognize that some of the stuff like exercising, which is great for cardiovascular health. I need to check to see what their blood sugar is before, make sure that they're not exercising with too little or low of a blood sugar, or in that they're also not dehydrated. So yes, and the biggest things we can do is just make sure they keep up with their treatments, their diabetes, stay compliant with their diabetes medication to help with their cardiovascular disease as well, just to get you started. All right, medication interactions and therapeutic monitorings. Let's see. So for each scenario, state whether action is needed. It should say action needs to be taken. Oh, sorry, I got it. Whether action needs to be taken or if no action is needed. So these are a lot of medications and then labs. So this is like kind of that next level. You can sit there and say, hey, I know what a normal blah, blah, blah is, but you know what it means in a situation. So client on apixaban with APTT of 36 seconds. So with this, what do you call it? The apixaban, that's a new age oral anticoagulant. So the one thing I remember about those is they normally don't have any therapeutic monitoring. So this APTT of 36 seconds, I don't need to do anything because there's no therapeutic monitoring. There's nothing the APTT can tell me about how the apixaban is doing. It's just irrelevant or unnecessary to look at this. So no action for one, or A. B, client on heparin drip with APTT of 95. So if I remember correctly, the APTT, I want it to be the happy zone, because remember you want it in that middle happy zone where they're not going to have as high a chance of clotting, but they're also not so high that they're going to have a high risk of bleeding, is that 46 to 70. And so 95 is on that high end. So if it's taking me 95 seconds in order to clot, that's taking me longer to clot. So I'm more likely to bleed. And so it just depends on the protocol, but most likely I'm going to maybe hold the drip for a while. I might decrease the dose, stuff like that. I will follow the protocol, but I'm going to need less is the overall picture here. I'm client on digoxin with potassium of 3.9. So I know there's stuff with digoxin and potassium because I know that a low potassium drives a high digoxin level and a high potassium drives a low digoxin level. And so this potassium is 3.9. So I have to know what's normal, and it's 3.5 to 5. And so their potassium is currently doing okay. They do not have an abnormal potassium here, too high or too low. I know some of you perfectionists or overthinkers right now. I know you're thinking, well, 3.9, that's kind of like 3.5. And so, it's on the low end, it's going down there. It's still safe to give the digoxin this time, but we'll definitely want to keep a close eye on that potassium. And if we're giving any other meds to decrease their potassium, we might just need to look at potassium replacement. I'll tell you in real life, not for exam purposes, that sometimes on certain meds and in certain patients, we like to keep their potassium above 4. But nursing school world, 3.5 to 5, baby. All right. Client on lisinopril with a creatinine of 1.9. So lisinopril is I was trying to be cute, but I really need to stop that because I never end up being cute or funny or anything like that, especially not this late at night after this long of a day. So I'm going to stop trying to be cute and do drums or do other stuff. At least I haven't done the weird kissing thing where I'm like, wow, at least I haven't done that in a while. So I'm starting to, get past that. So needless to say, the client on lisinopril, I was going to say, which is a ACE inhibitor, because my prils make my blood pressure chill. I have to see does it matter that their creatinine is 1.9? So with a question like this too, what you can ask yourself is, if I give this lisinopril and their creatinine is 1.9, could some harm come to them? And so what you want to remember about lisinopril is that it raises multiple things. It raises your it raises your potassium. It raises your creatinine. Um, and I was going to say something else there, but yeah, I'm going to just stick with those two. It raises your creatinine and raises your potassium. The way that it works, because it works through the kidneys, it can increase your creatinine. And because it's blocking the renin, angiotensin, aldosterone system, it can also block your, it blocks your RAS and it blocks the aldosterone, which causes you to let go of sodium and therefore hold on to potassium. So it works in both those ways. So I would be wanting to hold or concerned about a patient on lisinopril if their creatinine's high or if their potassium is high, or if they're getting something else that could increase their potassium. So for this, an action would be needed, and probably the action is going to be holding the medication. All right, so a client on digoxin with a digoxin level of 2.4. So a therapeutic, again, kind of that happy range. I don't want it too low because then it's not effective. I don't want it too high because then it's toxic, is 0.5 to 2.0. So if I'm at 2.4, I'm over that high end of normal, so, or therapeutic. So what am I going to be? I'm going to be higher risk for toxicity. So that is right. Last but not least, so the action there is I'm going to hold the med, call the doctor, etc. They might need to do some reversal or use the digibind to reverse it. So then the last one, client on warfarin with an INR of 2.8. INR of 2.8, therapeutic for warfarin, again, because we're just like the PTT, we want to be in that happy range. It's 2 to 3. So if it's less than 2, they're more likely to clot. And if it's greater than 3, they're more likely to bleed. So 2.8 is right in that happy range. So we actually don't need to take any action. Ooh, more questions. I know you guys are so excited. So it says, for each of the following medications and interventions, list whether it's appropriate, contraindicated, or unnecessary. So this is a great next generation style question. And even if you have a multiple choice question you're doing, it's great for the other ones. If you get a question that all of the answers are maybe correct, or some are, some aren't, it's great to do to change it into a question like this. Like, what if this was a question asking appropriate, contraindicated, or unnecessary? Or if it's like a SATA or something like that, you could definitely kind of change it into this kind of question. So first one says, when these are all about meds, I know you guys love med studying, it says increase potassium intake while on lisinopril. So lisinopril, we just talked about ACEs and ARBs, and that increases my creatinine and increases my potassium. So if I had an order or an intervention to increase potassium intake while on lisinopril, this could actually cause a lot of harm. So I'm going to say this is contraindicated. So think appropriate, it's good. It's going to help advance the patient's goal. Contraindicated, it can cause harm or pain, difficulty, issue, decrease in their goals, whatever. It's going to cause, really just think it's going to cause harm for contraindicated. Unnecessary means it's not going to cause harm, but it's not going to do anything to help the patient. So increasing potassium could actually lead to an unsafe rise in potassium, which could lead to death by dysrhythmia. So contraindicated. Check kidney function prior to administering atorvastatin. So atorvastatin, this is one of my cholesterol medications. I know I want to check some sort of function, but if I remember correctly, cholesterol is made in the liver, not the kidneys. And so I think I want to check my liver function, not the kidney function. So this is unnecessary. It's not going to cause harm to check it, but it sure is not going to give me any information that's going to change what I need to do with this atorvastatin. All right, check heart rate before administering amlodipine. So the dipines, that is a calcium channel blocker. And so amlodipine, is going to, amlodipine is one of the 3 meds that we want to check heart rate for. So I'll remember the ones that we want to check heart rate for. We want to check, it's BCD, beta blockers, calcium channel blockers, and digoxin. Those are the 3 that they need to have a heart rate. And do you remember what it's supposed to be? You're right. I just can't pull it off. I'm not one of those people that, can just talk to myself here and try to make this really cute and snappy. So I'm going to stop trying to pretend like I am that person, because I'm really not. So heart rate less than 60, I need to hold for beta blockers, calcium channel blockers, and digoxin. All right. So the next one, check creatinine before administering spironolactone. So here, the creatinine again, that's my kidney function. And it's saying, do I need to check my kidney function before administering a potassium sparing diuretic? Because that's what spironolactone is, a sparing a lactone, or a sparing a lactone diet. Oh no, I'm gonna stop. What do you call it? I catch myself all the time, and I'm sorry if my intrusive thoughts are coming out. I usually am better at hiding them, and lately they've been coming out more in my videos, but I'm also very big on what do you call it? I am, oh, sorry, this is my son coughing. I am the unique individual that I am. And hopefully, if you're still here, you don't mind that if I talk some BS in between this teaching. At least it's not constant teaching all the time and you get a little break, rest your brain, see if you're still paying attention. Anyway, so creatinine, do I need to check kidney function before giving a potassium sparing diuretic? So creatinine is, what do you call it? Creatinine is going to give me some good information for any med that's going to cause kidney problems. So now you think about, can diuretics affect my kidneys? And the answer is yes. So all diuretics, I want to know what their kidney function is because they can be hard on the kidneys. So I will want to check my creatinine prior to administration. The next one, check potassium before administering digoxin. So this is another one we have to remember. So remember with digoxin, if my potassium is too low, it drives a toxic or high digoxin level. If my potassium is high, it drives a low or non-therapeutic digoxin level. So absolutely, I want to check the potassium. Give a lozenge or gum to client taking atenolol. So this one I'm going to say unnecessary because atenolol is a beta blocker. We watch for diabetics. It's a cardioselective. So we do not need to, what do you call it? We do not need to do anything with like the dry mouth. So the ones that would be dry mouth is maybe people on diuretics. We talked before, students brought up in class like antihistamines and some of the other ones, but the big one here, the hypertension med that this applies to is going to be clonidine. So if you remember, it can cause all the D's, dizziness, dry mouth, and what's the other one? Dizziness, dry mouth, and drowsiness. There we go. Dizziness, dry mouth, and drowsiness. Got it. Just making sure I felt like I was saying the same thing twice. What do you call it? With atenolol, this is not applicable to atenolol. So I can tell them to do a lozenge or gum, but it's not going to do anything to help with atenolol. If this was clonidine, if this was a diuretic, it might be more appropriate. Contact physician if client on metoprolol has history of asthma. So this definitely would be true if this didn't say metoprolol, because metoprolol is a cardioselective. All the cardioselectives are usually A through M. So like we talked about atenolol, metoprolol, whereas anything that's N as in Nancy through Z, like nadolol, propranolol, those are going to be my non-cardioselective. Remember, there's also mixed, which are carvedilol and labetalol. Those also act like the non-cardioselective, where we are going to be worried. So if you're wondering the mechanism here, what happens is think of metoprolol as being very preferential towards the heart. It's just going to focus on what's going on in the heart and lower that blood pressure, heart rate. The other beta blockers, they want to do the same thing, but they also have some cells in the lungs. And so when they work, they help in the heart, but then they also can cause problems in the lungs where they can actually cause like a bronchoconstriction or a narrowing or a spasm in the airway. And so this would be very dangerous for people that already have narrow spastic kind of airways like asthma, COPD, and people that smoke. So contact physician if client's on metoprolol is going to be unnecessary. Whereas if it said if the client is on carvedilol, labetalol, propranolol, nadolol, all those, it would be appropriate. Check platelet level prior to administering Lovenox. So some people may say, no, there's no therapeutic monitoring for Lovenox. But here's the thing I got to tell you. Is that you have to remember that when we're checking levels for a patient, sometimes it's not always therapeutic monitoring we're doing. Sometimes we're also assessing for complications. So with Lovenox, you have to remember that they can have that risk for the HIT syndrome or heparin-induced thrombocytopenia. So any patient who's on a heparin product, whether it's Lovenox or more typical heparin, we all need to check a platelet count. Now they are less likely to get the HIT syndrome with Lovenox, but they still have a possibility. So we always want to be super careful, and we're going to check that usually daily. ask about muscle pain for a client taking aspirin. So, aspirin is more related to the GI bleeding. It's ototoxic. Take it with food, that kind of stuff. We want to be looking for bleeding, but muscle pain, not so much. So this one is going to be unnecessary. And so for muscle pain for a client, that would be necessary or appropriate for a client who's on a statin or fibric acid derivative. So that's why you always want to look, like when you're reading these sentences and if these were some of your answer choices, you always want to look and make sure that it's the right med and right symptom, or the whole statement is correct. Hold furosemide, so that one's unnecessary. So the last one, hold furosemide if potassium level is 4.9. Well, that potassium level is, what do you call it, on the higher end of normal, and furosemide is going to do what to my potassium? It's going to decrease it. So that's okay. It's on the higher end of normal and it's going to get a little bit lower. Sounds great. So it seems like it's a win-win. So this is appropriate. Oh, no, sorry. No, sorry. It says hold furosemide. So that is unnecessary. So like it's unnecessary to hold it if the potassium's 4.9. Sorry, I need to read more carefully. Actually, maybe I was testing you to make sure that you were paying attention. And yes, hopefully you're paying attention, and you corrected me and said, Mrs. Woodruff, that is not true. You have to read the statement fully. And so if you did that, great job at correcting me and still being awake. So let's look at this next one. Another open-ended. So 5 priority teaching points for a client with hypertension regarding their diet. So we want to think what we want the lows. If they're diabetic, we definitely want a diabetic kind of diet or a low carb diet. The big thing is the low sodium. We usually like low fat. And with the sodium, it's usually between like 1 to 2 grams. We usually like 1.5 if they can, but a lot of times they're going to be on a 2-gram sodium. Other priority, so that's the sodium. Then low fat, especially staying away from those bad yucky fats. We like, whole grains. We like fiber. We want to stay away from red meat. What else do we want? Let's see. I think that's a lot of the big points that I want to say there. I think that's the big thing. But just remembering some of the other places that, what was I going to say? Sodium hides. Deli meats, what do you call it? Processed foods, any sort of canned food, or like frozen dinners, stuff like that. All right, so now we're in some angina stuff where it says a client has a new onset of chest pain. What order would you complete these interventions? So new onset chest pain. So the first thing I want to do, because chest pain can sometimes be relieved when they stop moving or slow down, is I would have the client stop any activity and rest. So rest first. So after that, I would have them, I'd probably want to administer oxygen, because I want to go ahead. There might be a supply demand issue here. So I'm going to go ahead and apply some oxygen. And then I'm probably going to check on how they're doing and check their vital signs. If I'm going to give any meds or do anything further, I want to see how stable they are. Then I'll probably get an EKG. And a lot of people say, oh, no, you're going to give the nitro next. And the reason you want to do the EKG first is it's kind of like you want to get a baseline. This is not going to take long. We want to see how their heart is doing without giving them medicine first. If I give them medicine, it could stop whatever's going on in their heart, and I don't really know what's happening. So we're going to get a quick EKG. I thought I heard something. Get a quick EKG, give that nitroglycerin. Then we will probably, it really down to these two, it's hard to say. I would say maybe draw blood for troponin, and then administer the morphine if needed, because the morphine is going to come more later. It's just if the nitroglycerin doesn't work, we need to give the morphine. But yeah, so that would be stop, oxygen, vital signs, EKG, nitroglycerin, what do you call it? Troponin, morphine. Or if you had morphine, troponin, it's probably about the same. It just depends. The morphine we only give if they need it. It's not necessarily that they have to get it. Ooh, now we're getting into dysrhythmias. What do you call it? So this rhythm, remember, we have our systematic method. We just have to name it. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9. So I have a rate of 90 because I take how many QRS spikes there are and times it by 10. It looks about the same. It looks different in between each of these. So I have an irregular rhythm with a rate of 90. I have no discernible P waves. It looks kind of like fibrillatory waves. I do not have a P wave for every QRS. I have a skinny QRS. So I have, so it means I have to have a top of the heart problem. So I'm looking at a problem, top of the heart, which I only have 3 choices for rhythms here: AFib, A-flutter, or SVT. So I have a skinny rhythm that's irregular at top of the heart. So the only one that's irregular with a skinny QRS is going to be AFib. Yes, it could be flutter too, but with the fibrillatory waves, it's going to be AFib. So yeah, and a great thing to do after this is study, like, what would you do? What are your priorities and stuff here? I knew this question was coming up, so that's why I didn't go too much into it. So priority assessments to complete on a client experiencing a dysrhythmia. So if someone's experiencing dysrhythmia, some of the most important things we can do is to check their vital signs, specifically their oxygenation or SpO2 and their blood pressure. That's going to tell us the most information about how they're tolerating that rhythm, how they're doing in that rhythm. So those would be my priorities. See what symptoms the client's experiencing. How do I know a client with a dysrhythmia is getting better or worse? Will they be getting better if they are showing signs of good perfusion, if their heart rate is getting back to normal, or they're converting back to a normal rhythm? They're getting worse if oxygenation is decreasing, heart rate is, depending on which rhythm they're in, is getting too high or too low. Any signs of decreased perfusion, like especially also think mental status is a priority assessment to see how their mind is handling. Like if they're getting such bad cardiac output and perfusion that their brain is just like, it's time to go to sleep, that's usually a sign of that they're not doing well with their dysrhythmia. So check level of consciousness and orientation. All right, so now we are getting into some not diagnostics, but some procedures related to dysrhythmias. It says name 3 differences between cardioversion and defibrillation. So here, 3 differences for cardioversion. What I would say. Cardioversion versus defibrillation. The thing to know is this is the same machine. Like, so we're talking about a defibrillator, an AED. These both, can do something similar. So, but like in the hospital, we have the crash cart and then we have the defibrillator on it. These are the exact same procedure. We're putting pads on the client and it's sensing the rhythm, or stuff like that if they have one. And then we're trying to do different things in each of these, but I just want you to get the point across that it's the same thing. It's not something different. Cardioversion, the things that are different is that the patient's alive. So they have a pulse. They are in everything that we're going to do on the defibrillator. It's called a defibrillator, but we're using it to cardiovert. Everything that's on the machine that we're going to use to cardiovert is going to be turned on. So the synchronizer is on. We are going to have sedation on, and the sedation doesn't go. I feel like I just messed this up and went too deep into this. I was trying to make it cool, but I think this is what I'll say more. Cardioversion, let me just keep it simple. Cardioversion, they have a pulse. They're going to have the synchronizer on the defibrillator is going to be turned to on because they have a rhythm that we're synchronizing to, so that we don't shock them at a point when their heart should be resting. They're going to have sedation on because the patient is still alive, and so it's going to be painful. We do not want them to have to remember or experience that. And then we are going to use this to convert back to normal sinus rhythm or decrease the rate for a fast rhythm. So cardioversion is a converting procedure to slow down fast rhythms. So the 4 that it's going to be for this that you need to know about right now is going to be AFib, A-flutter, SVT, and VTAC with a pulse. Those are ones that we can cardiovert because they have a pulse, but it's fast, unstable electrical activity. Now, we do not we cardiovert fast rhythms. So like that last rhythm that I had with the patient in AFib that had a heart rate of 90, we're not usually going to cardiovert that because it's in like a 60 to 100. But if it was going super fast, or if they were incredibly unstable, and it still would have to be probably faster than what it was at in order to cardiovert them, because we usually do that for fast rhythms. Cardioversion cannot speed up the heart. It can only slow it down or convert it. For someone with a pulse, but in a irregular or more chaotic rhythm. When I say irregular, it doesn't have to be irregular like AFib. Again, we can also cardiovert SVT or VTAC with a pulse. So then defibrillation, remember the D in defibrillation is that they're dead. So the patient is going to have no pulse, but they have to have some sort of electrical activity. And then with defibrillation, the things that are different is there's no synchronization, there is no sedation. The other thing I forgot to mention is defibrillation has higher energy where cardioversion has less energy. Now, we don't need as much energy to convert a patient who already has a pulse, but someone who's defibrillated might need more electricity to get that jump started. And converted back to normal. The goal for both of them is to get back into a normal, stable rhythm. With cardioversion, they're in an unstable rhythm. We want to get them back to a more stable rhythm. With defibrillation, they have no pulse, and so we're trying to convert their electrical activity and get them back where they can have more stable, have a return of pulse plus stable electrical activity. The defibrillation doesn't actually restart their heart. Like it's not like a jump where a lot of people think like, where you can't shock that flat line, but defibrillation helps to get it back to more stable electrical activity and hopefully give it that jolt that it needs to get back into rhythm. So with defibrillation, like I said, no sedation, no pulse, more energy. And yeah, I think I've touched on that enough. I think I'm good there. So same procedure, but just the things that are different. Do they have a pulse? Are they going to get sedation? How much energy? And does it need to be synchronized? Those are the real differences there. All right, so this rhythm has these weird little spiky things coming down from it. So if you're not familiar with this, this is a paced rhythm. But if we gave this something like this on a test, we would want you to know, is it atrial paced or ventricular paced? So to figure that out, what you want to do is you always want to look at where the spike is. If it's before the P wave, it is an atrial paced rhythm. If it's before the QRS, it will be a ventricular paced rhythm. So this one is before the P wave, so we have a atrial paced rhythm. So yes, very good. Speaking of pacemakers, for each of these, let's indicate whether it's true or false for pacemakers and or ICDs. So true or false, for pacemakers, ICDs, microwave use should be limited. So this is going to be a big old false. You do not have to limit microwave use for pacemaker ICDs. Second one, I can take a shower the same day as my procedure. I feel like they have an incision that we don't want to get wet, so I'm going to say this is also false. Number 3, it is not safe to walk through the anti-theft devices at stores. A lot of times people get these mixed up with metal detectors. What I've heard is that you do not want to be chilling in the middle of an anti-theft device with a pacemaker, but it is perfectly safe to walk through if you walk at a steady speed, but you shouldn't be just like leaning in or being like, let's see what happens. So you shouldn't be chilling in the middle of the anti-theft device. So that one is false. I may set up metal detectors when traveling. That is absolutely true. So while they may be safe to walk through anti-theft devices, when it comes to metal detectors, they have this device in their body, so they should let people know, hey, I have a pacemaker, because they're probably going to have to go through a special screening process if they're at the airport, train station, etc. If I receive a shock, I should get help immediately. So when it comes to patients, this would refer to a patient with an ICD, because the pacemakers don't shock them, only the ICDs can shock. They absolutely should get help immediately. This is true. So this is not one of those things that I'm like, oh yeah, earlier I was having lunch and I got a good shock, like I'm converted back into my rhythm, into a normal rhythm. Like it's not something we're just gonna be like, I'm okay. It's definitely something we need to get help immediately. I should avoid any damage or trauma to my operated side. So what do you call it? You definitely, usually it's going to be the left upper shoulder, or not upper shoulder, the left chest, the left chest. And we definitely want to avoid any blows to trauma, no like chest bumps, no one should be punching you there, but you also want to watch that shoulder. We don't want to raise or move this shoulder. A lot of times we keep it in a sling to remind patients not to be using that side. I would need to have my pacemaker switched out every 10 years. So this is going to be false. You don't have to regularly have your pacemaker switched out. There may be times that it is required, but it's not like, hey, it's good for this many years usually. So they might need battery changes, things like that, but not necessarily that they have to get a new pacemaker every 10 years. Pacemaker will convert me out of atrial fibrillation back to normal sinus rhythms. That is false. Pacemakers help to increase the speed of the heart, not to convert rhythms. Now, a ICD can convert someone who's in ventricular fibrillation, or it can shock someone who's in VFib, but it cannot convert for AFib. So this would be a great time to go back and look at pacemakers and teach pacemaker versus ICD and what else did I not include here. Ooh, we got another rhythm. So this one, can we count a rate? No, not really. Is it regular? Absolutely not. Is there P waves? No. Is there QRSs? I can barely tell, but if it is, it's fat. And so what I'm looking at here is a fat, wide, irregular rhythm. Oh, you stop. So yes, fat, wide rhythm. And so if we have two ventricular rhythms, it could either be VFib or VTAC. And so VTAC, remember, it's less tacky in that it's like beautiful, uniform. V's, where if it's more chaotic like this, more fibrillatory, we're looking at VFib. So this is a great time to then think about, okay, what do I do? What's priority actions for VFib? So start thinking about that emergency protocol. All right, now we're getting into the last section. We're almost there. Oh, we stop. So what do you call it? The last section here where we're talking about heart failure. This is what we worked on today in class. So what lab or diagnostic result is most definitive for a diagnosis of heart failure? So we have BNP at 75. So I know BNP is related to heart failure, but I think it has to be greater than 100 for actual definitive results or diagnosis. D-dimer 800. So this would be definitive, the diagnosis of maybe a blood clot somewhere in the body, but not necessarily, and I don't even know if it would be definitive, but it would be telling that there's probably a blood clot in the body, but I don't know about it actually telling for heart failure. Ejection fraction 45. I know ejection fraction is very specific and helpful for heart failure. I have to think about what's normal. Normal is 55 to 70, so this is low. So I would think this is pretty definitive for a diagnosis of heart failure, but let's keep going. And last but not least, troponin 26. So, I mean, that's a sign that there's definitely some heart damage and that could be in heart failure as a result of this troponin, but it doesn't actually tell me, like I can't look at this troponin alone and say they absolutely have heart failure. So that's what to kind of keep in mind, that when we're looking at something like this, it's really asking us which of these alone could tell us they have a diagnosis of heart failure. So some people would jump right to this BNP because they remember that's the lab, but remember the number has to be right too. So the best answer here is going to be C. So what are 3 reasons you would need to call the physician or take further action for a client with heart failure? So if you remember, heart failure depends on, of course, right versus left, but things would be like worsening edema, gaining too much weight. It's like that 3 pounds in 2 days or 3 to 5 pounds in a week. And then we would want to report any worsening shortness of breath, decreasing oxygen saturation, worsening confusion, change in level of consciousness. What do you call it? Any sign that other organs are failing, like maybe if the kidneys are going to failure, decreased urine output, issues there with labs, things like that. And then we also talked about that one sign in heart failure where if they have that, especially it's more like a congested cough, but if they have like a persistent cough, it can be an early sign that they're going into pulmonary edema and having a serious problem. So I'd want to report that. All right, so for each, let's see, I think we got, oh yeah, this is the last one. Woo! No offense, guys. I love y'all, but I also love to sleep sometimes. So last but not least, for each of the following medications, state how it helps in heart failure and any special precautions with it. So all of these help in heart failure, but in a different way, because this is one of those things that I always bring up that you want to think about for this med, for what condition it is, because, all these meds could be used for other conditions too. And what I'm hoping for them or what I want them to do might be different depending on the disease process. So for heart failure, the first one is captopril. That's a pril, so that's a ACE inhibitor. We're going to use this a little bit different. You might want to automatically say, ooh, it's going to lower their blood pressure. Well, it might, but that's not why I'm giving it for heart failure. I'm giving it for heart failure because one of the ways that the body tries to compensate for my heart failure or make it better is it stimulates that RAS. But when it stimulates that RAS, that renin-angiotensin-aldosterone system, it actually increases my sodium and increases my water. And that is going to make things worse. And it's also going to cause vasoconstriction in the blood vessels, which creates more resistance, which makes my heart have to work harder to pump blood forward. And so with the captopril, what we're going to be concerned about is we're going to be worried about oh, yeah, sorry, before I finish that. So the captopril I'm giving to reverse the effects of the RAS system that's activated by the kidneys and heart failure. So I'm decreasing the compensation that the body's trying to do that's making things worse. So it's going to help because it's going to have less fluid retention, less sodium retention, and less constriction or resistance in the blood vessels. Special precautions, remember, ACE inhibitors report that they can have a cough, report it because it can lead to non-compliance or it could be a sign of angioedema. Check the potassium and the creatinine. And then avoiding all of those, like we don't want to do anything that's going to increase the potassium. So potassium sparing diuretics, potassium supplements, high potassium foods. Let's see, the fillers or something else. Salt substitutes. We want to avoid all of those. Furosemide. So this can help in a couple ways. So in heart failure, furosemide can help because it can improve symptoms because they can be short of breath, fatigued, like full of fluid. So this can help with their symptoms. But also if we have less fluid on the body, it's going to help the heart to not have to work so hard. Most of these all go back to cardiac workload. So special precautions for furosemide, it's going to be, it's the same ACEs and ARBs, and then diuretics all have the same stuff where we're worried about potassium and we're worried about creatinine. So I'm going to watch that closely. I'm going to tell someone on furosemide to take it first thing in the morning or early in the morning so that's to avoid staying up all night and peeing. And like where they could have falls because they're getting up in the middle of the night. If I give it IV push, it can be ototoxic, so I'm going to give it slow. I'm going to watch their eyes and nose closely. I think that's a lot of it. Maybe wait. All right. Digoxin. So digoxin, this is going to be one that's going to help to increase the patient's heart squeeze. So remember, digoxin can also do other things for like AFib, but for heart failure, I'm giving it to increase the contractility or the strength of the heart muscle. And so digoxin, special precautions, it can be toxic. So the therapeutic is 0.5 to 2.0. So check that, check a potassium before, check their heart rate before. The potassium, we don't want it too low or too high because it can lead to problems. The heart rate, we want it to be above 60 to give this medication. And then let's see if there's anything else I want to add there. We would look for those early signs of toxicity, like the GI symptoms or where the patient sees halos around everything that they're seeing, some vision changes. Then late, it would be a very low heart rate, bradycardia, or heart block would be the late signs. So yes, and then like I said, check the potassium and make sure it's not too high or low before giving. Carvedilol, that's a beta blocker. So this is going to be a lot like the ACEs and the ARBs. And we usually use ACEs versus ARBs, but the carvedilol, by the way, is so the carvedilol, that's a mixed alpha and beta blocker. And so we treat it like a non-cardioselective. So for all beta blockers, I'm worried about diabetes. It can lower your blood sugar, but more than anything, it can mask those signs of hypoglycemia. So watch their blood glucose closely. Sorry, I went right into precautions and I forgot to mention how does it help in heart failure. So beta blockers are used in heart failure because on top of the kidney stimulating the renin-angiotensin-aldosterone system, they also stimulate the sympathetic nervous system or the fight or flight. So carvedilol blocks that fight or flight, which helps to decrease their heart rate so their heart doesn't have to work so hard. There's more time for filling. And it also decreases some of that resistance in the blood vessels so that the heart is not working so hard to push out against the blood vessels. But carvedilol, so all beta blockers, no matter what. Caution with diabetics, just that we want to watch their blood sugar more carefully and things like that, and look for hypoglycemia because they might not show obvious signs. This is a non-cardioselective, or it's a mix, so it acts like a non-cardioselective. So I'm going to be cautioning smokers, asthma, COPD. Need to check the heart rate before, and I need to hold it if the heart rate is less than 60. Last but not least, hydralazine. This is a vasodilator. So we do talk about the vasodilators. We don't want to use them usually with other things like erectile dysfunction meds, including anything that ends in FIL, FIL, because it can have that dual thing. We worry a lot more about that with the nitrates, but it's possible with this too. So then Oh, and real quick, vasodilators, because it decreases resistance in the blood vessels, so it helps in heart failure because it's going to make it easier for the heart to pump blood forward. And so hydrolysis, and then the other stuff, just that, with this particular medication, it's not as much, but if this was a nitrate, it can cause flushing, which can be uncomfortable. But with this med, you might just want to check a daily weight or watch eyes and nose closely, things like that, just because they can have pooling of blood as a result. And remember, this can cause a very profoundly decreased blood pressure. So watch their blood pressure closely. So hopefully that helps. Hopefully you are the winner because you've made it through this video and you've survived me for yet another video. I know definitely it's been a struggle, and I know my jokes are getting worse and my humor is getting darker, but I'm glad you're still here, still surviving. Just know one day you won't have to listen to this voice anymore. Maybe, or you could come and talk to me and just say hi and tell me how things are going instead of having to listen to me incessantly rant. That is if that's something you enjoy. But anyway, I hope you enjoyed this lovely cardiac review. I hate to tell you, but it's all downhill from here. There's some kind of cool stuff coming up, but cardiac is the best. So anyway, I hope you enjoyed this. See you for the next one.